Welcome back, everyone. Let's get started. I'd like to welcome the next panel to the stage, beginning with our moderators, Jonathan Cohen and Angela Loder, Larry Zarker, Kevin Kennedy, Dominique Ruiz, Beth McGee, and Rachel MacCleery. This track discussion will be Community Solutions to Improve Health.
Thank you very much, Michelle. And welcome to the most engaged session that you will experience in this conference. We're going to ask you how you feel. We're going to ask you to tell us what you want to know. This is the place to find out everything you always wanted to know, but we're afraid to ask about this subject. Why did you come to this conference? What do you want to know? This is when you can ask and find out. We are going to ask questions not just at the end, but after every single speaker. So to start, I'm going to introduce myself very briefly before we introduce other speakers. I'm Jonathan Cohen from the Department of Energy. I co-lead the Health and Home Performance Initiative with my colleague Eli Jacobson, who's in the audience. I also head up a national network for residential energy efficiency called the Better Buildings Residential Network. So I have to say thank you to Chris from the last panel, who just gave a plug for Better Buildings, and I don't even think he realized that. So there's an entire program. There's a blizzard of acronyms of Better Buildings something something in the Department of Energy, because we recognize that that is, in fact, the key to this issue as well. So we are going to engage you early and often, kind of like what they say is like voting in Chicago. You're going to do it early and often. And we're going to ask you to give feedback to get a sense of the audience. So now that you've been energized by the yoga, we're going to first go over the agenda so you know what to expect. So who do you have here? You have me. You have Larry Zarker, the CEO of the Building Performance Institute. You have Kevin Kennedy, who is the Director of Environmental Health Programs at Children's Mercy Hospitals and Clinics in Kansas City. You have my colleague and partner in crime, co-moderator, Dr. Angela Loder, Vice President of Research for the International Well Building Institute. Dominique Ruiz from the same organization. Beth McGee, PhD candidate, University of Florida. Rachel MacCleery, Senior Vice President, Urban Land Institute. We're going to have questions after each person, and then discussion at the end. So get ready. Here it comes. First question. Are you ready to start with the opening poll? I said, are you ready to start with the opening poll? Yes, that's good. All right. Which discipline best represents your organization? Raise your hands if it's health. Okay, thank you. Raise your hand if it's buildings. Oh, very interesting. Okay, did not expect that. All right. Opening poll question number 2. Which sector best represents your affiliation? Raise your hand if it's government. Okay. Raise your hand if it's a nonprofit organization. Okay, got some hands out there. Raise your hand if it's business. Okay. Academia. All right. Okay. And raise your hand if it's the all-purpose and ever-popular other. Okay. All right. And then, opening poll number 3, before we get into the thick of things, which of the following best describes your organization's experience with integrating health and buildings? Would you say, and raise your hand, if it would be very experienced? Okay. All right. Variety of hands. Would you say it's somewhat experienced? Okay. Limited experience? And that's okay. All right. Would you say absolutely no experience whatsoever? Okay. And then not applicable for some reason. Okay. You always got to have NA. It's very important. All right. Well, thank you very much for being a part of the opening poll sequence. Again, you are going to be asked for questions after each speaker. So please, as the speaker is in the thick of their presentation, start standing up at the microphones so we can get right to you. And we really want to ask people who have not been asking questions to stand up so we get new voices. And please do focus on specific questions, and we'll ask you to say who you are before you ask the questions. With that, I'm going to go back and hand it over to my colleague, Angela Loder.
I'm Dr. Angela Loder. I'm the Vice President of Research at the International Well Building Institute. And I just wanted to give a little bit of hints of what we're asking you to do. We really want to make this session a not come here, hear a nice session, and then I'll go off and forget about it. We really want to have follow-up. We want to have something come out of this, particularly because we're asking for connections between the speakers. We're looking for those gaps. We're looking for those opportunities between the goal of this session, which is how do we have intersection between building-level health initiatives and community-level health initiatives? And the speakers range, going from more specific to a little bit more broad. You'll see we have a plan in mind based on what their expertise is. So our colleague, Dr. Whitney Austin Gray from Delos, and another colleague, your colleague, is going to be passing out sheets of paper or Post-it notes. We are going to be giving some guiding questions after the speakers have talked of things to think about that we'd love your feedback on, or any comments or feedbacks on where you think this needs to go, next steps, gaps in opportunity, who's not at the table, those kinds of questions. And if you so desire, you can leave your contact information at the bottom, and we will contact you after the session for follow-up. And with that, we have, yes, please go ahead.
Okay. I'm Larry Zarker. I'm with the Building Performance Institute. We've been talking a lot about buildings. I want to change the topic to homes. We all live in a dwelling.
Keep going. One more. Two more.
There we go. And my topic is our homes suck. And that's why our children have sinus problems. And, this isn't really a commentary on the construction industry. I've been in building research for over 20 years. It's really a physics question. Our homes suck because of stack effect. The air gets pulled into the building and it exits through the top. And what does that mean for us? It means that we're pulling in air that we can't trust, and we breathe it. And so think about this today as I'm talking about the place where you live and the things that bother you about your home or your apartment, that there are rooms that can't be brought to temperature, you have problems with drafts and that sort of thing, because this is real. And the reality is that there's over 134 million homes in the United States. Over a third of them are at least 45 years old. Another third is between 25 and 45 years old. So the great majority of our homes predate modern energy codes. So they're great places to live, but they don't perform as they should. And our homes are kind of, this is an EPA slide on the systems in a home. And I want to see a show of hands real quick. How many of you think if you get a house too tight, you can introduce problems with air quality in the home? So the majority of you think that. And I agree with you. The problem is drafty homes may be worse. And we'll get into that. So let's look at this red right here. Presume that that's like a crawl space, and that we're going to go inside that house and look at what's going on. Crawl spaces have a lot of problems. They have water. They have rodents living in them or dead in them. And the air passes through that into living space. And the problem with that is that our comfort systems actually pull that air through the supply and distribute it throughout the house. We breathe that air, and then it comes down through follow the blue lines here, comes down through the return where it finally meets the furnace filter. And look at this furnace filter. That is like what our lungs are experiencing in our home. So drafty homes have problems. And I lived in one for many years, 30 years in Tacoma Park, Maryland, and I was at the bottom of two hills, and I wrote this blog last summer. I was the cobbler whose kids had no shoes. My kids were athletes, played soccer, and they had sinusitis all the time. And I didn't put two and two together that we had a wet basement. And finally, somebody who was doing training in our house said, is your basement always wet? And I said, only when it rains, which is, pretty often. So I finally got that fixed, and I went down the path of learning about how buildings and health relate to one another. So that was a 100-year-old house. Then we got a house actually about a mile from here, and it's 30 years old. And I'm, say to myself, what could possibly go wrong? And you look at this slide on the right. We had a mildew smell, and so I removed the books, removed the trim, removed the bookcase, exposed a section of wall that couldn't ever dry. Wasn't a lot of water, it could never dry. This is common in many homes. And we're having, you're seeing mold here on the wall. The framing was rotted. And it was just a small little leak, right? A small little leak compromising the health of the occupants. So this is after a 3-inch deluge. That's not a lot of water coming in, but that's a lot of problem for the occupants. So this underscores the importance of treating the house as a system. And we know that there is an epidemic in the U.S. with asthma. There are a lot of research has shown that houses contribute to asthma through things like dust mites, cockroach dander, moisture in the house, and mold. And this slide shows the prevalence of asthma. So in the cohort of 17 years or lower, a surprising number of states have 10% of the population in that age group has asthma, and that number is increasing. And we believe that the house contributes to that. So this is a simple case of one contractor in Oregon. He was dealing with a woman who was scheduled to have thoracic surgery. She had 2 kids with asthma and were on inhalers. She lived next to a person who had heated with wood. And so they used a device called Air Advice to measure particulates in the home. So the number was very high before. Then they did the assessment, the energy audit, and decided to install, do air sealing, insulation upgrades, and install HRV, heat recovery ventilator in the home with very good filtration. You see the numbers coming down. And then afterwards, you see the numbers, and the kids lost their inhaler, the mom never had surgery. And what the contractor said to us is, this is tiny data. This is one home. You can't necessarily say that this is all of our homes. And that's the problem. The problem is we don't have enough good research data to show that this is the direction that we need to go. There is some data. The Green and Healthy Homes Initiative did 100 units in Baltimore. Kids with asthma, they upgraded the living environment and had a 67% decline in emergency room visits. And that translates into real money. The money that the insurance industry is covering for the ER visit or for the hospital stay. So there are ways to get at what the value of this is. Another case is in New Zealand. 188,000 homes were going to be upgraded for energy efficiency. They wanted to measure what the energy efficiency benefits were. Turns out, admissions to hospitals declined by 43%. Days off school, days off work went down. Over 90% of the benefits were actually health-related, which surprised them. So, again, There's some information, but it's not like the kind of information that we get from the pharmaceutical industry where they do double-blind studies, carefully designed studies. We just don't have that kind of research, and we need it. So the reason I'm here today is to say we need that kind of research to be able to make definitive claims. So we're a standard-setting organization, we're a certifying body, we created a Healthy Home Evaluator. This is a person who already has very strong credentials to use diagnostic equipment in homes, and then they get trained up to this new certification so that they can go in and through quantitative and qualitative techniques identify where the environmental issues are in the home and advise the occupants on what should be done. So this is a fairly new certification. People like Kevin and others in this room have helped to create it. We're trying to build a workforce that can go into homes and do this. So there's information here, lots of resources on reading up on health impacts. And with that, I'm going to turn it over to Kevin. I guess we're going to do questions first.
I want to invite everybody to come to the microphones to ask questions. We're going to ask questions after each speaker, just like was advertised. So now is the time to stand up and ask the questions you want answered.
Or not.
My name is Jonathan Cohen from the Department of Energy. So we have a question over here. We encourage everybody who has a question about what they've just heard to please stand up in the brief amount of time we've allotted after each speaker.
Larry, hi, this is Eli Jacobson. I work for the Department of Energy. I'm going to set up Larry for a moment here for a minute. So can you describe how you have seen contractors using health messages to actually sell home improvements? And can you help this audience understand their limitations and how they can talk about health?
Mm-hmm. So we see that a lot of the programs in the country dating back to the Arab oil embargo in the 1970s when we had long gas lines, a lot of the initiatives in our country have been designed to end our dependence on foreign sources of energy. That dates back to the 70s. All of the programs were about energy efficiency and providing incentives to reduce our consumption of energy. But that's not what people want. They want comfort, health, safety. They want durability. They don't really buy on energy efficiency. So the contractors have learned, the really good ones and successful ones have learned to sit down and ask questions like, where in the house are you not comfortable? Where are the drafts? What are the problems that you're experiencing? Do you have people in the house who have inhalers? And that drives them to actually solve problems, identify where the concern areas are, not try and sell windows, find the problems and solve them. And health is paramount for, our house is our castle. Where we live is important to us. So that's a big shift, and it's happening right now. So I think
Thank you. And we want to ask everybody, please say your affiliation and ask a question. If you do not ask a question in very short order, I will ask you to ask a question, or we'll move on to somebody who will, because we want to keep things moving here. So thank you very much for stepping up to the mic. Please say your affiliation, your name affiliation, and ask your question. Thank you very much.
Thanks for your presentation. My name is Li Yang. There are several aspects. The house has a problem. Maybe somebody put something like mold or something in your house, make it wet or make it infestation like mouse or anything like that. And they can also put the chemical maybe in your house and maybe make you lose your hairs and maybe change your appearances and things like that. So the consumers, the office or the home inspection, they will not give you any information who enter your house and whether they are coming to inspection or not. So what would you do?
Could you please ask a question, or we're going to need to move on?
My question is, there are maybe some costs or or there's a hazard or the mold problem, but that's because somebody put something, the material or some kind of liquid or something in your house.
Yeah, I get your point.
Right. Thank you.
And our, our people actually, we have like over 8,000 individuals who are called building analysts who sort of live in crawl spaces. Those pictures you saw are ones that they provided to me. They are trained to look for mold, to look for contaminants, to look for pests, to look for the things that you probably know about if you live in a home because you've seen it and you're embarrassed to talk about it. But they'll look for that and find it. And that's their job, is to help understand what is causing you concern.
Thank you. Can we have the next questioner, please?
Yes.
Say your name, affiliation, and question. Thank you.
Sadra Goldman, architect, sustainability consultant, BPI certified. One of the questions I had is, I find a lot of what BPI has as far as their certifications very, very interesting and very informative, but the barrier to people accessing that information, like the people in this room, is the cost. So I was wondering if you guys are working on anything so you can share your knowledge and share, like you had just talked about, the HHE certification, some of the knowledge from that maybe people don't have to get fully certified, but they can learn about it in a deeper way.
Brief, please.
Okay, so what's interesting is that the National Environmental Health Association had a certification called Healthy Home Specialist, and they discontinued that at the end of last year. And we actually purchased the intellectual property and the exam, and we're going to bring into the market, below this high-level Healthy Home Evaluator, we're going to bring an assessor or advisor and introduce that into the market that will be less expensive to get, and it will have the training that community health workers and others in the field can use. So we're moving in that direction too.
Thank you very much, Larry. I think that's all the time we have for this immediate brief window after the speaker, but we are going to open it up for fuller discussion after the last speaker. So please do hold that question. In the meantime, we're going to go to our next speaker. I'd like to ask Kevin Kennedy to come on down, as they say in The Price is Right.
Okay, thank you very much. I want to mention, Eli, a response to your question. You asked how the energy performance workers, home performance workers, could engage in a conversation about health. That is not the intent of the program. It is not to get them to engage about health. They are to engage in their expert knowledge about homes and home performance and environmental issues in the home. If they can engage and get homeowners to reduce those environmental conditions, to improve the indoor conditions, then the conversations that a homeowner has with their physician can be about the health issues and hopefully health benefits that came from that. So I work for a hospital. We have an environmental health program. It's a unique program in that we go into families' homes, specifically related to environmental impacts on children. We also have a program going into schools. We are consultants to some of our local school districts and help them in managing their buildings and educating and training all of their staff. We do research in the field of home and school environmental interventions, and we are a training center teaching the workforce to assess and characterize health and safety risks in homes and schools. We've been doing all of this kind of work for about 20 years. So we're a unique part of a hospital and represent the idea that hospitals need to and are now engaging more specifically in communities through a focus on social determinants. Many of you may have heard of the concept of upstream medicine, this idea that we have to look upstream away from what we're seeing in clinic, how they're presenting, what are the symptoms we're seeing here, what are causing those symptoms, what are the root causes. We need to look upstream at where that child spends time, what is their health condition, and what are the risk factors they might be dealing with, not just specifically in the home, although that's our focus, but all of those social determinants, I would call them social contributors, because these are things we can change that children are exposed to in order to improve their health. They are not determined. We can make change. Because the reality is, in the United States, we spend far more on healthcare and far less on social programs, social service and community service programs than any other country in the world. And this gap is growing. We're spending more on healthcare and, under our current political climate, less on potential social services that the rest of the world recognizes has significant health benefit that comes from being out in the community and engaging in best practices on the ground in neighborhoods to change conditions that people, especially children, are growing up in. Everyone in this room will experience a chronic health condition in their lifetime. You don't experience that chronic health condition in the hospital. Your stay in the hospital is temporary. You take care of your health condition at your home, in your neighborhood. That's critical in your care and recovery. And if a home condition is worse, then the ability to recover takes much longer, or it actually can make you significantly sicker. And many of the patients we deal with, that is the case. Our story started with kids in the asthma and allergy clinic 30 years ago with one of our doctors, Dr. Portnoy, our division director, recognizing the role environment was playing in patients he was trying to manage. He had them on all the medications he could have them on. He was doing everything the disease guidelines said he needed to do, and yet these kids are still chronically ill and still ending up in the ED or in the hospital on a regular basis. But because of his recognition of the role of the environment, with his own money, hired environmental hygienists to go to a home, assess conditions for some of these patients, recognize the exposures they were dealing with, connect with community partners, housing partners to address those issues, and saw the utilization of these kids go away, the medicine use go down. And that was what was stimulus to establish a program clear back in the 90s. So now, the green circle here represents your direct health care. The larger circles around the outside represent all of those other components that should be part of comprehensive care in managing children and their health and well-being. I've been fortunate to be involved because of the work we do in home environmental research, and we've done a lot of the environmental intervention kind of research associated with asthma and allergies and different types of allergens in homes. And through that work have found that there is lots of robust research by others to show a clear connection between changing home environments and seeing improvements in asthma disease and in a reduction in utilization, and seeing an economic return on investment for the interventions that were done in managing the disease, specifically the environmental assessment and home interventions, and how that resulted in significant cost savings to the healthcare system. Well, it turns out that through energy and home performance work, some programs evaluated chronic health patients in their work who were participating in weatherization programs or energy efficiency programs, and also found significant health benefit. These are two important reports that came out, one sponsored by DOE, one sponsored by an organization called E for the Future. And these reports showed, both for seniors and for children, significant improvement from various analysis of different programs, very significant improvement in health conditions. And Larry mentioned some of these case studies. This table is just showing that connection between the health symptoms and the improvements that were associated with specific environmental changes that resulted from weatherization. So really the model, the goal is, we know well the x-axis of this curve. We can measure pretty accurately the energy performance and how to make a home more efficient. We're beginning to understand what kinds of scores, what kinds of measurements we can take to show that a house is healthier. But again, our goal is to be in the upper right of this axis, what is both healthy and efficient. And that's our challenge and what we, in our work, have been working on. So this decision-making tree shows you how well correlated energy performance work is with healthy home or home environmental performance work. They align very well, and they are natural to be integrated, and the workforce that Larry has certified, the building analysts across the nation, are actually the experts on building diagnostics for understanding very specifically what those air pathways are, what the pressure differentials are that guide exposure from sources in homes to where people spend time. So they have the skill set, but we need to expand that skill set and get them thinking more about the house as a system and its role in environmental exposure. So our program has been doing that kind of work now for 20 years. We've been in well over 1,000 homes. We're unique among hospitals as far as home visits because we're not just doing a visit with a community health worker. We have on staff 5 environmental hygienists who go with a community health worker or with a health coordinator. They are very specifically diagnosing the building. They're very specifically doing measurements and sampling of environmental risk depending on the risk of the patient. So we stratify our patients based on what kind of risk they're dealing with and how sick they are, and offer a level of service that meets the health concern and the environmental challenges that they're reporting. We collect data in a very systematic way and score and rate those conditions so we can communicate back to the family very specifically about what our concerns were. But key to that is communicating both the positive about their home and the negative or the concerns we have that we want to try to address through the work we're going to offer. The work we offer, well, the other thing we might include then is some sampling and measuring data to support that. The work we offer is specifically targeted repairs, targeted changes to the home that the research has shown if we can change those conditions, it should reduce their exposure to certain environmental contaminants. We offer them free supplies that are donated by the hospital. We teach them and educate them about cleaning and about maintaining their home. We do specific services in the home. Now, that isn't the hospital doing the home repair work. That's us partnering with community organizations, housing organizations that have the expertise. They know how to manage contractors, and we have a long-term partnership with many of these organizations to have them do the work in the community with the family on their home, but they are engaged through their contact with us because of a chronic health condition. This just shows you some of the different costs, and then before and after. And then through this effort, we've seen a specific reduction in the utilization of these kids. They're out of the ED less, they're out of the hospital. So our goal is to reduce the impact of their home on their health. Just another example of that reduction. And then we don't do this alone. As I say, this is very much a program that is out in the community, so we have well over 100 different partners that all serve a different role. So it absolutely takes the village to provide this kind of service, and they all play a valuable role, but we all work together to try to benefit the families and neighborhoods in our community. Fortunately, the Affordable Care Act put an emphasis on higher quality care at a lower cost through the triple aim, and changed what's called the essential benefit rule several years ago, which changed who could do home visits. And it allowed for non-healthcare licensed people to provide services in homes, including healthy home assessors, environmental hygienists or assessors. But they left it up to the states, Center for Medicaid Services left it up to the states to implement programs. So it has moved very slowly. The state of Missouri is the first state in the nation to actually develop a policy that allows for the reimbursement of environmental assessors. So health insurance paying for the home assessments to help pediatric asthma patients. In my view, this could be expanded really to any chronic health condition. There are many seniors who deal with debilitating chronic illness and have lived in a home and coped with the conditions in those homes because of their limits in economic ability to pay for things that would tremendously benefit from a program like this. I want to point out, you mentioned looking for knowledge, the National Healthy Home Training Center, and we are one of those training centers and offer courses on a routine basis covering all aspects of health and safety and housing, including how to assess homes. All of these courses are available. That's supported by HUD, supported by EPA and CDC. So that's a place to get knowledge, and I'd be happy to talk to anybody about training afterwards.
Kevin, we're going to have to ask you to wrap up, and that's perfect timing. Okay. All right. We are going to now go to a very quick question period, as in very quick. So please say your name, your affiliation, and ask a question. If you say your question in about 15 seconds, we might be able to squeeze in 2. Otherwise, it's going to be really tight, and we'll have to save it to the larger discussion at the end. So we'll start here, and I guess move over there.
Sure, and I'm happy just to put this question out, and you all can answer it at the end. Joel Kimmons, nutrition scientist, Center for Disease Control and Prevention. I've heard a lot about how the environment affects people, but not how people's resilience, say their diet, affects that. So the number one burden of chronic disease worldwide is dietary intake. And so this needs to be balanced out. You go to someone's home, you think about how the house is affecting them, but how about their fridge?
Quite here. You're saying that, yes, diet plays a role. I certainly don't dispute that. What was your last part of that question?
Well, probably the major part of the home that is causing damage is the fridge.
Is the fridge?
The fridge. What's in the fridge?
Right, but
So
no question about that.
The resilience to everything you're talking about
Yes.
is dietary intake and physical activity.
Absolutely, that plays a role. No question about it. So you're not asking a question, you're just making a statement.
No, I'm sort of saying, how do you take that into your calculus?
How do we take it in? Well, that's not specifically through our program, but if it's a patient at our hospital, and our hospital certainly has a whole focus on weight management, on healthy lifestyles, and we have very specific programs, including community gardens, where we are out in the community teaching about nutrition. 5 years ago, our hospital took the step, and very few hospitals have, to eliminate sodas, to change our entire cafeteria and take out all the candy bars and sweets and switch over to fresh fruits and some locally produced stuff in our salad bar. So it's a long process, but you're absolutely right. It's a fundamental one.
Okay, thank you. We actually, unfortunately, have run out of time for questions during the immediate aftermath of the speaker, but we will have discussion at the end after all the speakers. Please hold those questions, and I'm going to hand it over to my colleague, Dr. Loder.
Okay, I'm going to introduce Dominic Ruiz, a colleague of mine who's going to be talking about some of the intersections between building level interventions and community level interventions through the well building standard.
Hello, everyone. So by a show of hands, who is very familiar with the well building standard? And who is not so familiar with the well building standard? Okay, I guess we have a little bit of work to do still. So just as a refresher, the well building standard is a performance and evidence-based certification system for measuring the impact of a building on human health. And the well building standard is spread across 100 features in 10 core focus areas, tackling things like air quality, water quality, acoustics, thermal comfort, you name it. And so we've been fortunate to and excited to witness and experience a adoption curve that's been almost too fast to keep up with sometimes. And so in just 4 years, 930 projects, 35 countries, as you see, cities and states. I think one of the most interesting things for our work has been entering new markets and understanding and being reminded what we've known all along, that health is not a one-size-fits-all, and that the health needs going into a place like China are much different than the health needs for people in their buildings in Canada. So that's been very interesting, and that's been something that we've really taken into consideration as we've come to new iterations of our program. So through regionalization, we have been able to really focus on some of our top markets based on adoption, and to make the well building center more flexible and customizable in a way that addresses health at the regional level. So the idea, as the standard is in its new pilot, you can put in the location, you can put in the type, you can put in the building infrastructure and also associate that with your health goals and your health needs. And the result of that is a recommended scorecard. And the fascinating thing, and the thing that we're really working to advance further, are the weightings. So weighting different features based on their geography and based on their needs, but also balancing that out with market feasibility and market readiness, because we realize some of these things may not be ready in a place like India, or maybe not feasible. So that's something that we've really worked to advance with various subject matter experts. And then one thing, I guess the dream is for this to get even more specific, for it to have even more of a direct impact. And so we are aware that the region, there are many disparities even in a county or in a neighborhood. So I think the dream 5 years from now could be to where a project in the Bronx could have a different scorecard than a project in Manhattan, New York. So you can see where we hope to go in the future, and so that's very exciting for us. But really focusing on health equity, we see the disparities even within blocks, within buildings. And one thing that's been the driving force behind a lot of my work recently has been that low-income minority communities are actually faced with the worst environmental conditions in their buildings. And so, that's something I've really been wanting to, and Angela as well, is raise awareness to that issue and how we can tackle it through our buildings. And so, really, also elevating the need for performance and performance testing and understanding the problems that exist. So, with the Well Building Standard, it is heavily grounded in performance and understanding through verification, the air quality standards, the fundamental water quality, et cetera. And I asked the question, why is this important, which we get asked quite often. It's important because things like this often happen, too often, and too often are forgotten about. I think yesterday I was evacuated from a building in New York because of the pipe burst, and that pipe was built in I think 1932. And so the asbestos had basically exploded and spread across multiple buildings in New York City. And that's something that frightens me, that people a couple weeks from now could forget about that, and that they aren't constantly thinking about what that building, has that been remediated, has it not? And same thing with some of the things coming out in Flint, Michigan, is we are finding out that the water quality, the issues haven't been really fixed. And so, how, I guess another question is, how do you build that into the public conscious? And I think that also, really expands the role of a building and our standard to also engage communities and other stakeholders in the conversation. And so, one thing that we've done to help facilitate that dialogue is, we added a community concept, which is focused on community and civic engagement, integrative design, collaboration, community access, also surveys and evaluations to really engage other stakeholders in understanding what a community really needs. So that also happens through other concepts and through other features of the standard. Also in areas of movement, which is focused on physical interaction in a building and also in a community. So where we've seen this become successful is in the city of Chicago. So in 2017, the city of Chicago decided that they wanted to take on healthy buildings, and they wanted to build it into their sustainable development policy. So for the first time ever, they've included the Well Building Standard and actually weighted it heavier than the other certifications. Just to give you a sense of how that works, so any building pursuing public funding over $1 million, which I would imagine is all of them in Chicago, they're required to meet a 100-point threshold, and that 100-point threshold can be met through LEED, through Energy Star, through many other different certifications. But we were really excited to see that Chicago was thinking about this as an even more comprehensive thing and extending the notion of environmental sustainability to really put emphasis on the humans as well. So we're very excited about that, but I guess the shortcoming of that is we have noticed that it hasn't resulted in an uptick yet, and I think that really is telling us that we need to do more education. We need to spread the awareness even more in some of these areas. And so my call to action is help us drive equity into our program. And that's something that we're very focused on in the next year to 2 years. And we are looking for partners to help bridge that gap, just knowing that in affordable housing projects and schools and homeless shelters, we want to increase the access to buildings of all types in all communities. And I think we need help by other partners and other affiliates and colleagues to help get us there. So that is all I have. Questions?
It's time for questions. Thank you, Dominic. Do we have any questions? Wonderful. Thank you. Please go ahead.
I live in a house in this neighborhood, an individual home. After I lived there a few weeks, I found that I would get sick whenever I turned on the heat. And I brought in a chemist who told me that there was chlordane in the under the house, which had been put there to keep termites from eating the wooden structure. The ducts were the return air ducts were automatically built in to the base of the house, that is into the foundation, and there was no way they could be used to return the air to the furnace without the chlordane, which had been injected under the house, entering the ducts. So I decided I would abandon that house and build a safe one. And I hired an architect for whom I have already spent over $100,000. But when I began testing materials that would go into the house, and I found that is, I would send them off to a chemist. And the chemist found toxics that were in these building materials which the manufacturer did not identify. So I could not trust what I was told was in the building materials. And thus I've gone back to the other house, used electric space heaters for heating. But I am told that is very inefficient way of heating my 6-room bungalow, but I do it anyway, and I will not allow these energy evaluators to come into the house and evaluate it.
Okay, thank you. Thank you very much.
Hello.
Hi.
My name is Sarah Hayes. I work at the American Council for an Energy Efficient Economy, ACEEE, and we have a program there on health and environment. And we're actually having a conference in December that will cover building materials and many other of these topics, if you're interested. My question is, I think the first two speakers made a compelling case for energy efficiency and its links to health. And I am less familiar with the Well Building Institute standard, but I was wondering if you could speak to that a little bit, how efficiency is included, and if it's not, is there some plans to include it more?
Yeah, so that's a very good question. In the evolution of the Well Building Standard, we worked very closely with other green rating systems, other green building organizations such as U.S. Green Building Council, to understand how we can make this work harmoniously with sustainability. We didn't want to see, we didn't want this to be seen as a conflict to the 25 plus years of the green building industry. So an example of that harmony is water, for example, where a LEED certification or maybe Energy Star or other green building certifications are focused on water usage. The Well Building Center would be focused on water quality and removing the different sediments in your water. And, I guess to my point earlier of the aging infrastructure, so at the municipal water treatment facility, New York may have, some of the cleanest water in the country, but that has to travel through hundreds of miles of infrastructure that's almost 100 years old. So the water that you're getting at your faucet is much different than the water that's coming out of the treatment facility. So that's the part that we're very interested in uncovering and prescribing solutions to, and those things don't conflict necessarily with green buildings. So that just gives you a kind of a zoned-in perspective on that.
I have a question for you. You mentioned that which is very exciting, that Chicago has included the WELL Building Standard as one of I'm just assuming the sustainability metrics. What do you think are some of the factors that enabled that to be successful? Because I know Toronto, for example, also looked at incorporating the WELL Building Standard into their green buildings matrix, and it wasn't successful for different reasons. So could you maybe talk a little bit about that?
Yeah, so Chicago is an interesting case, and not dissimilar from Toronto, because they are great leaders in sustainability. I think, in Chicago's case, it was really, it was the Department of Public Health that had driven, part of the effort alongside the Department of Planning and Development. And, then the city of Chicago being a leader in LEED certification, that also involved, AIA and BOMA and Enterprise Green Community Partners. And so it was interesting. I think that they just were able to get more stakeholders involved. And also, the mayor, Emmanuel, is very interested in advancing healthy communities. And there's a thing called, Healthy 2.0, which is the mayor's plan to address health in buildings and communities and their design. So it was a lot of those things that contributed to the success, and they are still having that dialogue and including more people now to expand its impact. So it's very exciting.
Wonderful. We have time for one question. Okay.
Hi, Megan McAvoy, GBCI. I was wondering, in terms of access to disenfranchised communities or those that are suffering exponentially from health impacts, what IWBI or Delos is doing to help those communities get access to WELL certification or steps towards that pathway, since I know there's a lot of expense associated with the testing and whatnot.
Yeah, it's a great and timely question. So one thing that we did introduce actually a couple months ago was a discount for low income, for affordable housing projects, for governments, for nonprofits, and that's a 35% discount from its market rate. So knowing that it still can be expensive and infeasible for some of those projects in disadvantaged communities, that's where I think that we really open it up to other partners to help us understand how to bridge the gap. And so we are wanting to draw those stronger connections to help unlock new funding mechanisms for underprivileged communities. So that's something that I think we're very early on, and we have started the conversation by introducing a discount. But still, in terms of filling that gap, we're still trying to figure that out.
Perfect. Lisa, do you want to hold your question? I want to make sure that
Rachel has time. It's just a point of order. It's not a question. I just want to make sure that people understand that those who are disabled, who have been exposed to pesticides or something, may speak more slowly or be more long-winded. And I think it's really important for us to be empathetic and let them finish their thought, because we're not all like 25, and sometimes it will be a little slow.
We just have 5 speakers, and we're trying to make sure that the last speaker has time, because we always know they get shortchanged. So absolutely. And we will have time afterwards for questions. Okay. Thanks, Dominique. We're going to change a little bit of a pace here, because the connections between buildings and communities can be broad and there's different facets. We've got Dr. Can I say doctor yet? Almost Dr. Beth McGee, who has done her work on biophilic design and a wonderful toolkit. And so this is another way to think about potential linkages between the exterior environment and community level initiatives and building level initiatives.
Perfect intro. I am within a week or so of getting my degree, so I'm in the middle. This is the first public exhibition of this work that I've been working on, so we're excited to share it all with you. Title of this is Supporting Biophilia in the Interior Environment. I'm an interior designer / interior architect by training and by education, and so yesterday, Heather said, where can we make the most impact? And that's the interior. And that is kind of my own personal view as well. So this is where my focus has been on looking at biophilic design in the interior. So I like to start with this quote by Rick. When nature inspires our architecture, not just how it looks, but how buildings and communities actually function, we will have made great strides as a society. Biophilic design provides us with tremendous insight into the why, and then builds a roadmap for what is sure to be the next design journey of our times. And this has definitely been a hot topic, I think, coming up in the design world. But I actually think that the roadmap is really not well laid out yet, and so I've been trying to address that issue myself in my research. So a little history and then a little bit about what I'm going to be talking about, just to catch you up if you haven't been familiar with biophilic design. Of course, it's based on biophilia, the innate need for us to commune with nature, and that's being applied to the built environment. That was originally proposed by Stephen Keller around 2008, actually earlier, but it was really promoted in 2008 in a book that they produced. Later, I used his list of attributes that he originally created. It was about 74 features, and tried to, for the first time, bring those to the interior. And I used 66 of those to really start to see if those were even being used in the interior. I used hospital playrooms. I did 24 case studies and found that almost all of them really were being used to a various degree, but they were present, and the biophilic design matrix that I created was actually one of the first attempts at this, and it was actually pretty reliable when we did some of the testing. So from that, it kind of gave me the impetus to keep going and to develop it more. So going back to get my dissertation, I've been working on that even further, and really went back to the beginning, though. Went back to the drawing board to reevaluate all of his original features, make sure this was a broad application for any type of commercial, mostly, environment is what I've been looking at, not just healthcare spaces. And through a series of testing, which I'll talk about, we updated that to 54 attributes, design attributes that can be used. In this process, I'm also trying to link research, adding tools for designers, using interior design students and practitioners as voices in this process, and also developing color and light as a topic in it. So what I'm calling this now is biophilic interior design, because it's kind of a more focused approach. Still using the six main categories, which Keller called elements. And one, I have tweaked the name of it and actually just literally finished updating it, so it's even new. It's not on the slide. Element 1, actual natural features. These are the ones that everybody thinks about. So this is like the plants. Okay, we got to have biophilic design. Everyone says, oh, bring in the plants. But there's a lot more to that. There's, I think there's 9 features in that one. Natural shapes and forms. This is just like it sounds. It's about the shapes and forms of nature. So a picture of a flower, for example. Element 3 is the natural patterns and processes. So this is things like fractal design, you might hear, has been in the news also. Then element 4 is now called light and color. That is because it was originally light and space, and I was going to change it to color and space, and just recently updated it to light and color because of this addition of Margaret Portillo's color planning framework that I had adopted and adapted to increase our color, light, and materiality presence in this. Because this is an interior design focus, it really wasn't as prominent in the original list of features, so that's been a huge adoption. And it was very actually something that when I was getting feedback was really kind of a useful tool, I think, that was missing before. Element 5 is place-based, so this is the idea of connecting with the community, looking at the local geography, looking at a sense of place, and again, rooting it in geography. The last one is human-nature relationships. So these are dual things. So things like prospect and refuge is a common thing that people might have heard about. So this was the actual development of this was a 2-phase process: the development, and then we did some testing. So the development process in phase 1 did result in 54 features. This was through a series of cognitive tests with practitioners, and they assessed a space, and I was able to score that accordingly. Through that, the names and the definitions were definitely clarified. That was something that was a key finding, was that although Keller was an amazing mind and a brilliant researcher, I think a lot of us who are researchers, we use language that's not always easily applicable for the common person, we'll say. So trying to make that language more useful, user-friendly for anybody at any level was one of the things I worked on. That was part of the reason why I did students to practitioners. So anybody beginning the practice of design all the way through really advanced like 25, 30-year experience practitioners I was allowed to test. So this really helped to develop that. Through this, definitely the validity has improved, and it's definitely much more user-friendly, which is a bonus. So phase 2 was an actual survey of practitioners, and then I did a separate survey of the students using the tool in a studio project. So I got 2 different data sets. Out of that, definitely there's a lot more clarity in what I'm calling the biophilic interior design matrix, which was a little bit of a change in nomenclature from the original one that I released in the Herd Journal a few years ago. So the reliability was really good. It was actually seen as being useful in all design phases. So that actually was a new finding because I had never tested it out in the actual design process before. So the students being able to use it in the design process was really exciting. They were able to be engaged with the matrix throughout. And we did a kind of a semi-controlled study where half of them did not have it and then half of them did, and were able to compare and get their feedback. And the ones that did have it were really more, the students thought it was very important, and their confidence and their knowledge increased after they used it. And like I said, the practitioners also think that biophilia is important, but their use and their confidence actually was kind of moderate. So the students actually, even at the beginning, kind of thought it was more important, but the practitioners definitely, as they used it, the practitioners haven't been using it. As they, I think hopefully as they are able to adopt the BDM or the BIDM, they are going to hopefully also increase their confidence. So a couple of the quotes that were found in the study. This could be a great checklist to share with clients as part of a design process. So again, using the user-friendly language to communicate our design intentions to the client, I think that's a key finding, a key intent also of the tool, and also having it being a worthwhile study, but having this deliberate system of defined vocabulary is helpful. And I think that's an important thing. That was one of my goals, and so we're getting there. So the toolkit has a bunch of different parts. It's available on the website now, and we'll get to that. But one of the things that came out of it was a checklist. They said we want a quick, fast way. Once we understand all of the definitions, we're going to internalize them. We want to be able to just kind of go through it. So this is the master list right now. They are kind of categories like you see with the 6 categories, but this is kind of the I don't want to say a dummy sheet, but the checklist. It's not a checklist like LEAD. It's a lot different than that. This is meant to be just a reference, and it's a design guide. It's not you have to get all of these to be biophilic. It's not you have to do really well in a certain category to be biophilic. This is actually a designer's toolkit where they have complete control. You're going to use your own mind to figure out what's appropriate for the culture, what's appropriate for the client, for the environment, that sort of thing. So regarding evidence-based design, my goal is still to link evidence with these attributes to help us as designers and help clients to understand how we can really use these attributes as well as appropriate examples and case studies. I want to link case studies and images and pictures and everything for designers. So it's a quick one-stop reference. So each of these on the website has the name, the definition, some examples, and research as I'm finding it. So that is one thing I'm hoping to get additional funding for. Partners with other people doing research. There's tons of research out there. Just literally haven't had the time to get to it all. But the goal of that, for the future would be really helpful, I think. So overall, just some highlights. People do, at least interior designers, are seeing that biophilic design is important, which is an exciting thing. It has been an interesting outcome that people now, with it being a design tool and not just a post-assessment tool, which it originally was, is finding that it can increase their creativity. They're very open to, creating these unique design solutions. It's not just a mandated solution. Also being able to guide their design decisions throughout the process. Additional research is needed, additional labor is needed to help link some of the research that's already there. There's tons of research there already even, but a lot of these are so specific now, I think they haven't even been in the radar of people. So this is our ability now to kind of look at this list and reassess as researchers, maybe to get ideas on how we can help to support some of these design decisions. The nice thing about this is I believe that it really is a support system for helping people with the Living Building Challenge and WELL. Those two specifically because they have biophilic design in their core structure, and they both reference Keller's original list. So this being based on that helps to create this bridge of familiar, user-friendly language that maybe we haven't had, and as well as the tactics that now are available, those examples of how we can achieve those. So restorative environmental design was originally posed by Kellert, and the idea was that we had been working on sustainability at that time, and we were really missing this idea of biophilia. So connecting biophilia with restorative environmental design is what sustainability is what restorative environmental design is all about. And I just kind of diagrammed this to show everybody quickly the idea that we might be working in a little bit of a silos, but we do all need to come together at the beginning of the table, sort of like the BIM model has been, trying to talk about how we're each contributing to this at the beginning of the process. I think if we're adding research and evidence to these features to our design process, that's going to help us all be able to communicate to stakeholders. That was one of the comments I got from some of my practitioners was, this is great, similar to the other quote, that now I have this language, I can talk about these things more implicitly and explicitly based on what the needs are of the project. So my goal is hopefully with all of these to help you kind of spread the word of how we can, what's really needed still, how we can connect this to existing projects in the future and other research or everybody kind of contributing, and how this can maybe help build our restorative environmental design for the better of our planet. That's all I have, and this is the website in case you want to write it down.
Thank you. We have time for a couple of questions. Does anybody have? And the other speakers are able to ask questions as well. Wonderful. I've finished on that side of the room, so let's start on this side of the room.
Oh, me? Oh. Thanks for the presentation. Quick question about dose and response with biophilic design. I don't really know a lot about this, but is there a dose response at all factored into this?
Wait, what did you say? A response?
Like the dose response, is there a threshold to a point where there's too little or too much?
Yeah. So because it's so nascent, this research I feel like has been kind of simmering, but it's not really well developed yet. We don't have that yet. My goal is maybe to continue testing that to see if there is a minimum or a maximum. If you do this as a post-assessment occupancy evaluation, for each of them there's a range that you can score your space. So you get a score at the end of it, but right now because I have only tested a few spaces, I don't have that data, but in the future there definitely could be. This definitely links to my previous research I did with some colleagues out of Bryant University with the child life specialist that I had. I basically had this pictures from my thesis that we used in that study of playrooms, and we had them assess them, and the more variety were the playrooms that they preferred as well. So more biophilic variety really did lead to more, the perceived presence of a better playroom. So I think that is our innate need, like biophilic design is, that the more variety we have, it's just like nature is such a varied environment. So when you're able to kind of build up more of these features in a thoughtful, well-designed way, you can't just throw out like all of them and then they're good. It has to be designed really well. That's the important part. That's the designer-driven part of it. So yeah, hopefully in the future.
Talk to after about that, but that also has to do with the research perception. Nature is pretty different in that we're not just little widgets and you get an add nature plus person equals outcome. Right. Nature is very symbolic. We have cultural values around it. So I think when you hear dose response model, you should be a little cautious because humans don't work quite like that.
Yeah.
One last quick question,
please. It's very
please.
individual, I feel like. That's one other thing I want to tell everybody, that it's not like a one-size-fits-all. Yeah.
I think this kind of builds off of what you had mentioned before. I was curious if there was some sort of ranking or prioritization system for the different elements in the checklist, if one or two, if you could only do one or two, do you prioritize them in that way?
Good question. So that is why I'm linking the evidence, so that you as a designer or a stakeholder are able to look at the evidence and do your own assessment, because I feel like there isn't a one-size-fits-all or a ranking. But I will say, in general, the first category of actual natural features, if you can get those in the built environment, they by far have the most evidence, and they by far, I think, have the most direct impact. So if you have actual plants, actual living, running water, fresh air, all those things we've been talking about, I think those are the immediate ones. But a lot of the times we can't have them for certain reasons. It's a healthcare setting, nosocomial infections, things like that. So then we need those indirect. We need the representations of nature, and we need to think about maybe how we talk about the culture.
Wonderful. Thank you. And our last speaker, last but not least, is Rachel MacCleery with the Urban Land Institute. And Rachel is at the end because she is the broadest in some ways, and so hopefully is tying all of these different pieces together.
It's a tall order. So I'm Rachel MacCleery, and I work at the Urban Land Institute, and I'm delighted to be here today. ULI is a research and education nonprofit that is focused on promoting best practices in real estate development and land use. We work through our 40,000 members who are all real estate development professionals, designers, public officials, other folks that are involved in land use. And we provide them with research and convenings and networking and opportunities to learn. About 5 years ago, ULI launched the Building Healthy Places initiative out of a recognition that the real estate industry can do more to promote health and wellness through their projects. The initiative is working to leverage the power of ULI's global networks to shape projects and places in ways that improve the health of people and communities. And we really see our members and really all land use professionals as working in three spheres. They can promote health and wellness through their leadership of their companies, through their project and investment decisions, and in their communities. So no human being only wears one hat, really thinking across levels and opportunities to promote health and wellness. We've done a lot of research and have a lot of publications and activities, and I encourage you to check them out at uli.org/health. We're a private sector driven organization, and so we pay a lot of attention to what people are looking for, what they want, what they'll pay for. And our research shows that people are, there's a lot of demand for healthy places out there, but that there's not enough supply. So when you ask, people will tell us that they want to live in places where they don't have to drive very often, where there's transit, where it's safe and easy to bike and to walk. But people also report that their communities don't make those kinds of healthy behaviors easy. 25% of the country says that traffic makes it unsafe to walk in their communities. 48, nearly half of the country says that bike lanes are insufficient. 38% don't have access to outdoor parks and recreation spaces, and 16% don't have access to fresh and healthy food, one of the most basic ingredients of healthy living. And these are, sort of general averages, and what we find is other research shows that low-income communities and communities of color tend to have the least access to healthy places. So for now at least, the country just isn't really very good at promoting health and wellness. And I think this panel is looking at the different kinds of scales that health and wellness happens at. And I think it's helpful to think at a variety of scales. And all public health interventions will need to operate across a variety of scales. People spend most of their times in buildings, but buildings are nestled in neighborhoods. Neighborhoods are located in cities that influence job opportunities and educational outcomes. Cities are part of regions that are part of countries that are part of the world. And each of those scales, whether it's climate change, opportunities for physical activity, access to healthy food, they all impact an individual's ability to be healthy. As we've talked about today, the building trades have long had a focus on really protecting health and safety, protecting people's lives, making sure that there aren't hazards that can be avoided. And what we're seeing now in the industry is really a shift where the building trades, architecture, real estate development are thinking about what can we do to help people be healthier? How can we proactively support health and wellness and meet those market demands for healthier places, healthier buildings? And that effort will take the public and private sectors working together. Nearly all real estate is privately held, and so the private sector really needs to be part of any larger public health interventions to promote health and wellness in communities. So it's a very exciting time to witness the rise of the health certifications. We've heard from Well. I think folks from Fitwell were here yesterday. There's another certification. It's a small one and that's based out of Colorado called Certified Healthy. And I think these certifications are really responding to the demand for health and wellness among the real estate industry, making it easier for people to understand how to promote health and wellness in their buildings, and really making health and wellness as core to real estate development as sustainability has been for the past few decades. And we see that happening across a number of different realms. We've talked about energy and the connections between energy consumption, climate change, and health. And I just wanted to highlight one area that we've done some work in around active transportation and biking and walking. And this is just one sort of sphere where you can see where public health, public investments and city investments and infrastructure that promotes health and sustainability really needs to be complemented by private sector development and private sector choices in order for them to be most effective. When you think about a bike trail, people aren't actually going to use that bike trail if there's no place for them to park their bikes when they get there, take a shower if they need to, and that all happens within the buildings. So I'll just talk about a couple of examples where the private sector has really gone above and beyond to be in the mix when it comes to active transportation. So Minneapolis has been very assertive in investing in active transportation infrastructure and biking and walking. The Midtown Greenway is an example of that. It's a high-speed bike system that connects South Minneapolis to the downtown. It's known as a bicycle freeway because there's actually two separated bike paths in each direction of travel, which is a best practice, along with a separated pedestrian path, so you can avoid the pedestrian and bicyclist conflicts. And it's really led to an explosion of development along the corridor. When it comes to active transportation, when we looked at this report, what we saw was that across the country, there's kind of a new kind of TOD. I think people are familiar with transit-oriented development, and we're seeing something called trail-oriented development. So the Midtown Greenway is an example of that. There's been a number of development projects that have sprung up along the Greenway. Property values have increased over the past few years, and the market is really responding to this new transportation infrastructure. Mosaic is an individual property that's located adjacent to the Greenway but didn't actually have access to it, so the developer contributed funding to build a bike and pedestrian ramp. It was a $370,000 facility, and the developer contributed about a third of that. It also has bicycle storage and locker rooms with showers, and the proximity to the Greenway has been a key part of their sort of marketing and positioning strategically. Another example is in Indianapolis. Indianapolis has built the Indianapolis Cultural Trail. It's a $63 million 8-mile trail. Unlike the Minneapolis Greenway, it doesn't really connect the downtown with the suburbs. It's more of a downtown circular path that connects cultural districts in the city. It has a lot of public art amenities, and it's really led to an explosion of biking and physical activity in the city. When it first started, there wasn't bike share systems, so the hotels had to provide it. They all had their sort of ad hoc bike share that people could check out. And now there's a city-run bike share system. The city estimates that 1 million people use the Indianapolis Cultural Trail each year, and it has also led to an explosion of growth where projects are locating close to the trail, adjacent to it, and many new projects are coming online. And Circa is one of those. So it's a multifamily apartment building that is close to the trail. It's got about 250 units. And the proximity to the trail is a key part of the amenity package that it offers. So it's got bike share, a maker's room, bike storage. The location close to the trail is a key aspect of how they talk about the development. Here's the bike storage. It's got storage for 150 bicycles, which replaces about 8 cars, actually. So you can fit a lot of mobility into a small space. And as I said, it's got a washroom and a storage. So these are just a couple of examples of how the private sector is sort of in the mix in helping to complement these very significant civic investments in active transportation infrastructure. I think this country has a long way to go to create a very seamless pathway for active transportation and biking and walking. There's too many places where the sidewalk ends, where there's sort of weak links in the transportation network, and the private sector can really help fill in those gaps by providing places to store bikes, tweaking the design so it's easier to get bikes in and out of buildings. We're even seeing bike valet parking. So just like if you were in a car, you could bike your bike up and somebody will take it and park it for you. So these kinds of strategies are helping to make biking and active transportation more prevalent and convenient and sort of build the bike culture in this country. But it's going to take more work. I think when it comes to active transportation, and we see this with food and creative placemaking and energy efficiency and other strategies, what it will take is more partnerships between the public and the private sector to really kind of take things to the next level. More understanding of what the actual community health needs are, and we've heard about that a little bit. So forging strategies that are really addressing the health challenges in communities, prioritizing investments in places that are the least healthy, and significantly more work to measure health outcomes, especially within building envelopes. So there's a lot of evidence at this sort of public scale outside of buildings, but we need to build the evidence base about what matters for health, what changes behavior, what changes outcomes and productivity within the building. And I see that as a real area for opportunity, for innovation and opportunity. What we know, though, without having to do the research, is that people are more likely to be healthy in places that put their needs first, and these are not people in cars, they're people as human beings, walking around, using bikes, getting what they need, and communities are more likely to thrive if they put the needs of people first. So people are more likely to come back, spend money, engage, be active, and that in turn leads to more successful places. You can be in touch with me by emailing me at health@uli.org, and look forward to the discussion. Thanks.
Great.
Do we have time for questions?
Yeah, I think let's move right to general questions. We're a little bit running behind because of so many wonderful questions people have had. Do you have the clicker? Do you mind just moving the... Yep. And then I think we're going to move Did they do the question slide? Let's see if there's...
Oh, we turned it off.
Oh, you turned it off?
Mm-hmm.
Okay. Well, that's fine. Any questions? And also, now would be a great time. I know we're running a little short on time. If you have any questions or comments, what are some gaps and opportunities you see from the speakers today for moving forward? Who's not at the table that you think would need to be at the table to make these connections between building level initiatives and community level initiatives? Specific questions you didn't get a chance to answer for the panel, and ways you'd like to see us talk about moving forward. Nick, first question.
Hello. Thank you. My name is Jennifer Roberts. I'm actually an assistant professor at the University of Maryland right here in College Park. And actually my question is specifically for you, Rachel. I do a lot of research in physical activity and specifically active transportation. And I was just curious, it sounds very, very exciting, but I'm always thinking about some of the unforeseen side effects, such as transportation-induced gentrification. And so what kind of measures are you all thinking about to preserve diversity in communities so that the people who are there can reap the benefits of active transportation when you have new trails or new light rails coming in? Are there any measures or things that you're thinking about to remedy that?
Yeah, right. So across the country, there's very justified concern about, you make investments, whether it's public investments or private investments, and that leads to then rising rents and displacement. Different community, I would say that nobody has the perfect solution to this. In DC in particular, I think there needs to be more emphasis and speeding up of affordable housing and other strategies. There's ways to address gentrification pressures through tax policies. There's ways to anyway, a variety of different things. I'm sorry, I just blanked. And we are actually working on a toolbox because we recognize that this is a concern for many communities across the country to look at the different suite of policies that are possible out there.
Great. Next question, Cedra.
Hi, Cedra Goldman. One of the things that I see as a big barrier here is cost, especially for assessment improvements and certification, especially for nonprofits. I personally am very interested in this and have donated my own services to get the Red Cross through LEED existing building. But I was wondering if any of the organizations up there have either looked at putting aside money to help fund nonprofits specifically in getting or improving their built environments, or have considered linking practitioners that may be willing to donate their services for like recommissioning and things like that that really lead to healthier buildings, and linking them through maybe some of their websites or other resources that they have.
I know that it's something that we're looking at. I don't have a clear answer for you yet. I think it's still very early, but we are facilitating these kinds of discussions, as I said, to bridge the gap, just because not only do you have the certification, but you do have the hard costs, and that can be very prohibitive for an existing building, in an affordable, for an affordable housing project or something. So we are trying to find different organizations like community, like CDFIs that also provide grants or funding to support these types of projects. We're really kind of lining up all of these potential partners and communicating these connections to try to make those things available. So very early still.
And I have a quick question, Kevin. You said that there's, they do the retrofit for the energy, and we've talked a lot today about chemicals. We've talked about, other types of things that can arise with retrofits. Is there a process of material selection which links to some of the stuff in Well and links to, a little bit of a crosstab between all of us? Is there a process so that when they rip out the carpet and they put in, say, some kind of hard surface, that they're not adding extra problems because of VOCs, which we know can be difficult to... We can measure them, but there's a lot of debate around what we're measuring, what the health impacts are.
Well, and that's part of the process is offering to the families opportunities for different kinds of products that might be used, and then obviously we're advocating for reducing just the general use of chemicals in their homes and offering lots of alternatives, even in the practice of cleaning, which also includes maintenance, and then talking to them about new material selection. But the reality is, too, is that we are a safety net hospital. Many of these are low-income families, so they don't have the financial capacity to buy many of these things themselves. We'll try to offer them alternatives and work with them to pay for some of those alternatives, but that's a big challenge within low and middle income families. They don't have significant economic resources to make the kind of choices that we'd like them to have available, and for them to go to any of their retail outlets and find those things on the shelf where it's easy for them to get to. They may not have cars, they may not have the ability to take extensive trips to go to the one place that has the green materials in town. They may have to go to the neighborhood retailer, and does that neighborhood retailer have alternatives?
Perfect. One more question. Yeah.
Thank you.
You were next in line, correct?
No.
Sorry? Oh, you were next in line? Great.
Yes. Hi, my name's Dee Nicholas from Drexel University. I'm an assistant professor, and I also direct our program, our MS in Design Research. I've had many experiences where I've worked with community providers around healthy living, and what we've discovered is that a lot of times there's no way for the wraparound care that this population needs to occur because the partners cannot communicate, and they're all asking similar questions but not the same questions. So there's a lot of fatigue on the part of the underserved communities that we're trying to help. And I was just wondering if I could hear more specifically from Kevin and maybe Larry about any experience you've had with partners trying to share resources, share questions, share questionnaires, other than the obvious privacy issues and the sort of like HIPAA issues that might come up, because I think those are things that would operationally be dealt with. I'd love to hear about that.
And I'll say that's a phenomenally great question, because as I alluded to, we have some 100 community partners, and one of the great challenges that is often the case for people offering services like social workers and people within clinics is all they've been able to do is offer people hard copy applications. Okay, here's 30 applications for all those programs and services that you would benefit from, and they want to help you. There's a new program that has been implemented in 2 states and 8 cities, and that we are implementing in Kansas City. It's been around a while in those states. It's called One Touch. And so it's one of these models. It's a web-based system where you get all of the community partners that you want to have involved, and it helps to start small with a few and build up. But they all work together to build a uniform questionnaire that they all can agree has the key questions that are important to their organizations. All of the caseworkers use the same tool. It's a web-based tool. When they are in a clinic or in a home, ask the 35, in our case, we've developed a 35-question survey based on how those questions are answered by the client, by a family in our case. Once we have their responses, it is designed to be a non-HIPAA compliant survey, so you don't have to be HIPAA compliant. They're generic questions, but they are ones that target where there are health needs without asking specific health questions. Based on those answers, once you hit that you've collected it, it automatically connects to all of those agencies and sends the information about that client and provides the referral. So it's a very robust system that's been developed, and we're just starting to use it. But you need to use technology like that in a way to overcome these communication barriers and streamline the referral process, and that's what we're trying to do.
So real quickly, the Green and Healthy Homes Initiative helped us in developing the certification that I mentioned earlier, and they do this coordinated what they call ABC, align, braid, coordinate, so that all of the social services in a community that a person would need, they help them kind of like One Touch, connect all of that so that they get the services they need.
Great, and with that, we are out of time. Round of applause for our speakers, please.
Thank you very much. Ladies and gentlemen, just for your just as a reminder, lunch is on your own today. The cafeteria is out the back door, to your left, up the stairs, first right through the glass doors, and the cafeteria will be there on your left. Please stop by our scholars poster sessions. They would love to have conversation with you about some of the work that they have independently done. It's really interesting information out there on the poster boards. When you come back from the cafeteria, if you like, you can bring your lunch to room G1, G2 and look at Generation Zapped. It's a very interesting documentary about electronics and how it's affecting your body, and it's won film awards. Really interesting. I sat in for a little while, for as long as I could, to take a look at it. So feel free to do that if you like. And if there are any scholars in the room, scholars, please come back to the auditorium, I would say, since it's almost 12 noon, at about 12:10 so that we can take pictures.